We have Professor Larijani here.
Is he among the panelists? Invite him to be a panelist, please. Thank you very much. Thank you, and thank you very much for attending this webinar co-organized with IDF MENA region. So this webinar is to celebrate the World Diabetes Day and discuss how to improve access to diabetes medicine and care in EMRO region. Well, my name is Hisham El-Berri and I'm a medical officer in charge of NCD management in WHO EMRO, the regional office. And I will be facilitating this webinar. I would invite you, please, to use the chat box to introduce yourself. And please keep your mic on mute unless you want to speak, of course. So without any delays, I will invite Maggie to play the message from our regional director on this occasion. Please, Maggie.
Laptop.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Diabetes is a major public health challenge in the Eastern Mediterranean. The region has the highest prevalence of diabetes worldwide. Diabetes causes premature death and health problems such as heart attacks, stroke, blindness, kidney failure and amputation. At present, 55 million people are living with diabetes in the region, and by 2045, this figure is expected to rise to 108 million people. World Diabetes Day is an opportunity for us to raise awareness of how diabetes can be prevented and controlled. This year's theme is improving access to diabetes medicines and care. This year also marks the 100th anniversary of the discovery of insulin, an essential diabetic medication. WHO aims to support countries in integrating diabetes medicines and care into primary healthcare services and the Universal Health Coverage Agenda. WHO member states in the Eastern Mediterranean region recently took a major step forward on this by endorsing a new framework for action to address diabetes as a public health challenge, with the aim of halting the rise in diabetes and reducing premature deaths from non-communicable diseases by 2030. Today, we urge countries in the region to raise the priority given to the prevention and management of diabetes by implementing the strategic and cost-effective interventions set out in the framework for action to reduce the risk of diabetes and its complications and ensure that all people who are diagnosed with diabetes have access to equitable, comprehensive, affordable, and quality treatment and care. The framework also supports the prevention of risk factors like obesity, physical inactivity, unhealthy diet, and tobacco use. Together, let us transform our commitments into action during and post-COVID-19 to build healthier communities with better access to diabetes, medicines, and care, and to ensure health for all by all.
Thank you very much, Maggie. That was maybe the message of our regional director, Dr. Ahmed Al-Mandari, in the occasion of the World Diabetes Day. Dr. Asmus, the director of NCD, was supposed to give also an opening remarks, but unfortunately he couldn't be with us today. But the main message in his talking point, and I wrote them here, that indeed, and as mentioned by our regional director, diabetes is very particular in our region and reached the epidemic levels. And despite rigorous effort over years, and despite the availability of evidence-based guidelines, many patients with diabetes do not achieve the recommended target, and there is a need to improve access to diabetes care and medicine. So together, ministries of health, non-governmental organization, academia, public health association, clinicians, health workforce, and of course, people living with diabetes, we need to come together to assess the challenges and to try to find a solution together to build healthier community and a better access to medicine and care. So it's time to act now. So maybe I'll stop here, but that was maybe the summary of the talking point from Dr. Asmus, and I will invite Professor Jamal Belkhadir. Professor Jamal Belkhadir is the chair of IDF MENA, and please, Professor Jamal, the floor is yours.
Thank you, dear Hisham, dear friends and colleagues. In the occasion of the celebration of the World Diabetes Day, it's really deep pleasure and honor for me to be with you in this wonderful meeting organized by WHO EMRO in the presence of many international experts inside and outside MENA region, and with the participation of eminent persons from WHO. The main objective of celebration of World Diabetes Day 2021 is to draw attention to important issues related to diabetes prevention and management and keep diabetes in the public and political spotlight. World Diabetes Day aims to promote the importance of taking coordinated and concerted actions to confront diabetes as critical global health issue. This year, the World Diabetes Day, with the theme Access to Diabetes Care, if not now, when, coincides with the insulin centenary. It's wonderful to see that all associations in MENA region celebrate this event, focusing on the importance of access on medicine and insulin in the management of diabetes. Otherwise, it's important to see that COVID-19 didn't stop us to have great scientific and social activities in the world and in our region. This meeting, organized on the occasion of the World Diabetes Day, give me the opportunity to thank all the members of IDF MENA associations, the health professional care in MENA region for their effort in the fight against diabetes. Dear friend, at the end of my message, I want to express my deep thanks to Hisham, PP, Awadallah, Ayman, Slim, and Asmus from WHO and all speakers. At the end, I wish a lot of success of this meeting and hope to meet you soon face to face in the MENA countries. Thank you.
Thank you very much. Thank you, Professor Belkhadir. And maybe we need to go to kind of through the provisional or through the program. Please, Maggie, can you just put the program? So our webinar, so if you talk about our objective, is to present diabetes prevention and control initiatives globally and in our region. That is maybe the first objective of this webinar. The second objective would be if we can discuss and identify what are the barriers and the facilitators to access to care and managing diabetes. And maybe the third objective would be to provide recommendation to optimize diabetes outcomes. And I will go quickly through the agenda. So after this opening remarks, so we'll have, next slide, please, Maggie. So we'll have a session from WHO and we'll have a kind of updates from our colleagues from HQ, from the headquarters Geneva, on the Global Diabetes Compact and how the Global Diabetes Compact will improve access to essential diabetes medicine and technology. We'll have a presentation to talk about the economic burden of diabetes, and then from the region here, we'll introduce the regional framework for action on prevention and control of diabetes. And for the second session, and it will be mainly IDF, so we talk about the accessibility to medicine for high-risk type 2 diabetes with specific complication, and we'll have a second presentation on accessibility to insulin for type 1 diabetes. Then we'll have a panel discussion. So, and we have like 4 eminent panelists with us. Then a last session before the closing remarks would be a kind of a poll questions to audience. We want this webinar to be a kind of interactive, and we need to have a kind of guidance from the audience about what we can do better to improve access to diabetes medicine and care in the EMRO. And we have 3 questions for the audience for that session. So without any delay, so we'll start maybe the first session, and we'll start, next slide, please. Maggie, we start with an update from our colleagues in WHO. We have with us Dr. Bianca Hemmingson and Dr. Bashir Nous from HQ. So I will give the floor to you to talk about the Global Diabetes Compact and how this could improve access to essential diabetes medicine and technology. Over to you, Bianca and Bashir.
Thanks a lot for the introduction, Hisham, and thanks everyone for attending this webinar. My name is Bianca Hemmingson. I'm a medical officer working in the headquarters, and I will, together with my colleague Bashir, present the work we're doing in the Global Diabetes Compact and focus on the work we're doing on improving access to essential diabetes medicines and technologies. And please go to the next. Yes, perfect. Thanks a lot. In May this year, a resolution on diabetes was agreed, and the resolution urges member states to raise priority to diabetes. The resolution also lists a lot of requests to the Director General, which are listed here. I will not read all of them aloud, but some important points are considering the potential development of targets for diabetes. There are also other important things: strengthen the monitoring and surveillance of diabetes, and strengthen implementing policies, and also strengthen diabetes in humanitarian emergencies. And the next slides, please. Other things that are directly related to access to diabetes medicines and health technologies is the request to harmonization of regulatory requirements for diabetes medicines and related health products, and transparency of markets of diabetes medicines and related health products. Other things that are also a request is sustained financing of diabetes, and we should also provide a report on progress. And please go to the next slide. Good. In April this year, we launched the Global Diabetes Compact. It was a summit together with the government of Canada, and we have a huge representation of head of states and ministers of health from all regions to come and provide their perspective of diabetes treatment and care and what is needed. The vision of the Global Diabetes Compact is to ensure access to equitable, comprehensive, affordable, and quality diagnosis, treatment, and care to all. And there's also support of prevention of type 2 diabetes in the compact. And please go to the next slide. Since the launch in April this year, we have several other key milestones or key events, and several of these are directly related to improving access to medicine. For example, we have had the dialogue with the pharmaceutical industry. Other things is that we have established the Technical Advisory Group for Diabetes. We have also established a Global Diabetes Compact Forum, and most recently we have had the World Diabetes Day, which has a focus on access to medicine and care. And please go to the next slide. The compact consists of 6 work streams, which should not be seen as silos, but they all interact with each other. The first one, which Bashir will tell you more about after this slide, will be access to essential diabetes medicine and associated health technologies. But we also have technical products there in the potential coverage targets from the resolution, prevention, health promotion, health literacy, country support, research and innovation, and governance strategy and partnership. And I think now I'll give the word to my colleague Bashir to tell more about the work we have on access to essential diabetes medicine and technologies. Thanks a lot.
Thank you so much, Bianca, and thank you to Isham and to colleagues for the opportunity to present to you the Global Diabetes Compact and to specifically speak about our work that we are currently doing on access to essential diabetes medicines and associated health technologies. So as Bianca has just mentioned, workstream 1 of the Global Diabetes Compact specifically is on diabetes medicines and health technologies, and we have a few activities that we have started to work on to improve access to these critical medicines. If you look at the bullet points that have just been provided on the slide, slide 1 to 4 is really important of an overall agenda to improve the work that we do via private sector dialogues to get commitments and contributions from the pharmaceutical industry, but also the health technology industry. WHO have, as per our mandates, developed asks to these companies to help us improve access to these critical products in low and middle income countries, including humanitarian settings. Some of these asks range from pool procurement to the participation in pre-qualification to ensure the relevant quality of insulin and other health technologies like blood glucose monitors and HbA1c. But once a company makes a commitment, what's really important is to ensure that those commitments have an accountability mechanism. And therefore, as part of the same mandate that we engage to strengthen those relationships with those companies to get commitments, is to then register those commitments and making sure that they can report this and make sure that there's an accountability and transparency mechanism to monitor the progress that has been made. So through these dialogues that have taken place between February and September, there are already a few companies that have come forward with commitments, and I'll show that on the next slide. But really, what is important is also that we can't just think only about insulin. We can't only think about blood glucose monitors or strips, but we are expanding that mandate to include the latest EML products like the SGLT2 inhibitors as well. Some of the work that we're also doing under the compact is around cold chain integration. And what's really important with this work is that insulin is a temperature sensitive product and can really benefit from all the work that's being done around the vaccine rollouts for COVID-19 and the cold chain infrastructure that's being put in place. Like oxytocin, like snake venom, insulin can also go with the same infrastructure to really decrease that pricing of escalators across the supply chain. We have also started conducting webinars to really understand what are some of the barriers that we're trying to solve. In May of this year, what we did was we had a pool procurement hard talk. We also had a spotlight webinar which involved a lot of the member states and also our regional offices to really understand what are the challenges that are being faced on the ground to improve access to these medicines. We're also in December hoping to go through what we call a collaborative development workshop and really looking at aggregated demand and supply mechanisms to support our member states and ensure that they also can have access to quality, affordable insulin via potential UN mechanisms that can be leveraged. As Bianca mentioned, we also have our WHO resolution, which has put strong emphasis for us on pricing and affordability and regulatory harmonization. We are also hoping in 2022 to continue these dialogues with the pharmaceutical industry to secure those commitments and to get many more, because the ones that we have now is not going to be enough and many more need to come forward. Next slide, please. So some of the commitments that have already come through from the companies include the participation in our pre-qualification program, which really ensures the quality of the products that are produced for insulin, blood glucose monitor strips, and HbA1c. Some companies have also agreed that they will participate in the UN international procurement mechanisms when these are established and up and running. And some have come forward also saying that they will participate in the register so that we can ensure the accountability and move forward and monitor these commitments over time. One aspect has also been on providing data on heat stability of insulin, and that needs to be shared with WHO, as this is an important piece of work, especially in humanitarian settings. In terms of the next steps from what we are currently aiming to achieve is really to translate all these efforts through the compact to a country level. And so that means, of course, webinars like this specifically helps us to get a better understanding of those barriers that are very specific to your context. We are also going to be releasing a COVID-19 report in the first quarter of next year, really looking at the risk mitigation barriers that can assist member states and give them and provide them with options of how to take things forward beyond the pandemic, but also future-proof them for future potential emergency type environments. We are also in the process in the next biennium on working on a NCD forecasting tool. And that will come specifically not only a tool, but a guidance document and a training manual of how we can improve not only diabetes medicines, but more broadly NCDs, including respiratory diseases, cancer, and hypertension. We are also hoping to continue the work that we're doing. And we're grateful to all the colleagues who are part of our current surveys. We want to really move and continue our MedMon surveys to look at the challenges around affordability and availability at the PHC level, really sampling and looking at what's happening at the lowest level across our value chain. We are also going to continue to explore these collective negotiation and aggregated mechanisms to improve access at the more aggregated level and bring those prices down. And really what we are doing is really working as closely as possible with many implementing partners to support us as a collective so that we can be very coherent in the response to improve access to these crucial medicines. Next slide, please. And so I'd just like to end off with this specific slide, which is the keeping the 100-year-old promise on making insulin universally accessed. On the 12th of November, just before World Diabetes Day, WHO launched this report on the areas of action to improve access to an appropriate use of insulin and associated technologies. And it came out with 5 key areas for us to concentrate on. The one, of course, is to improve the availability. The second piece is to enhance the affordability, to really address the access problems associated with the devices and services, building capacity and investing in infrastructure, and supporting R&D. Bianca has just shared the report with you in the chat box, and I would encourage everyone online to have a look at the report and make sure that they are also aware of some of the challenges that we really are all trying to solve as a collective. So at this point, that would be my last slide. And so I will then hand back to Hisham as our moderator, but really thanking you on behalf of us at HQ for the opportunity to address you today and looking forward to our further discussions. Back to you, Hisham.
Thank you very much, colleagues, and thank you for this comprehensive presentation and to give this comprehensive overview on what has been achieved and what you are doing and what are the next steps. Thank you very much. And thank you for sharing also the links. I think it's very, very interesting. So we'll move to the second presenter. And we have with us Dr. Khalifa Al-Musharraf.
Doctor, before we move on to the next presentation, may I remind you of the group photo that you wanted to take for all panelists? And
well, thank
you. Would you like to take it now?
Yes, thank you very much, Maggie. What do you think? If we can, yeah, this is a good idea. Can I invite everyone, please, to open his camera? So we'll take a photo, a group photo for, today.
So whenever everyone is ready. Oh, hi, Dana. Okay. I'll just save this one and we can take another one just in case. Okay. Ready? Smile for the camera. Okay, thank you, everyone.
Thank you, Maggie. Thank you very much. So our next speaker is Dr. Al-Musharraf, Khalifa Al-Musharraf. Khalifa Al-Musharraf is a senior lecturer in public health and the director of public health program in the Medical School University of Limerick in Ireland. So Dr. Khalifa, the floor is yours.
Thank you very much, Hisham, for inviting me to present this study that was done in collaboration with the WHO. And I will try to summarize the study within the next 10 minutes. We tried to estimate the economic burden of type 2 diabetes in the 22 countries in the region. So what we did that we used prevalence-based bottom-up cost of illness approach to try to estimate direct cost and indirect cost of diabetes. The direct cost include things related to healthcare expenditure at the private sectors and the government sectors. That include costs related to admission, procedures, outpatient clinics, investigations, medicine, and so on. And in the direct cost, it's mainly the productivity loss as a result of sick leaves or absenteeism, or reduced productivity at work due to diabetes, which is presenteeism, or premature death. We use different sources to estimate that, which range from the STEP survey, the International Diabetes Federation, the WHO Global Health Expenditure, the World Bank, the local literature, the Ministries of Health reports, to try to come up with these estimates. So if we look at the region, which is 22 countries, the GDP collectively is more than 3,000 billions per year. And we have more than 700 million population in this region, with 240 millions as labor force. Next. So this slide gives the epidemiological landscape of diabetes in the 22 countries. We have more than 60 million diabetic patients currently living with diabetes, and we have more than 60,000 deaths every year as a result of diabetes. So when we look at the economic burden that include the direct and indirect cost, our estimate is that the annual economic burden of diabetes amount to more than 60 billion US dollar per year, which is equivalent to 1.7% of the GDP. And this is range from 0.7% to 2.2% of GDP between different countries. But let us look at this structure of the burden. And you can see that, the previous slide. So we can see that 22% of this burden is a direct government expenditure on diabetes, and 22% is a private expenditure. But then 56% is due to loss of productivity, mainly as a result of loss of productivity during work as a result of diabetes, the presentism. Next, please. So let us look again at this more specifically to see what is the visible part of the burden and what is the hidden part. So the visible part is the direct cost that government and private, and out of pocket and all these kind of expenditure, which amount to 26 billion US dollar, and this is constitute 0.76% of the GDP. But the invisible part of this burden, which is the productivity loss, it's almost 34 billion US dollar, which is equivalent to 0.93% of the GDP. Next. So let us look at the three different groups of countries within the region. So the first one is the GCC, and you can see that 6 countries, the burden on them is almost 27 billion. Then when we go to the group 2, which is 9 countries, I will show the countries in the next slide, but the 9 countries, the burden is 26 billion. But then group 3 is 7 billion. So you can see the main difference between the 3 group of countries, which is basically divided based on their GDP and economic status. The main difference actually is in the public health expenditure and the private expenditure. Look at the group 1, 29%, while this reduced to 22 and 23. But the private sector or the private expenditure on diabetes in group 1 is 12%, and this almost doubled in group 2 and group 3. And this reflects clearly the burden on people in group 2 and group 3 is almost double the burden on people, direct expenditure compared to group 1. Next slide, please. So this slide shows the economic burden of diabetes as a percentage per GDP in each country. The blue lines are the direct cost, and the orange is the indirect cost. So if we click, if you have one click, please. So you can see next, yeah. So you can see that in group 1, that Bahrain is the highest economic burden, and this then reduced, then we reach United Arab Emirates, but they're all still within that range between 2% and 1.5% of their GDP. The next group is starting from Tunisia and Lebanon as one of the highest economic burden as per GDP, going to Syria and Jordan, but still we're talking about within the same kind of average between 1.3 to almost 2.2. And then you can see the same pattern happen in the third group, but with less scale in Yemen and Djibouti, but still group 3 GDP, the burden of diabetes as a percent of GDP range from 2.2 to almost 0.7. Next, please. So this gives more idea about the structure of the economic burden in each country. So the blue column represents the public expenditure. The orange represents the private. The private include private sector, insurance, out of pocket, all of these expenditure. And then the gray represent the absenteeism, the yellow represent the presentism, and the light blue represent the premature deaths. Next. So you can see in group 1 that presentism is dominating and the public expenditure. Next. Here you can see the similar pattern, but still with fluctuation between different countries and there are many different socioeconomic characteristics that affect this pattern, many prevalence and other factors. And when you look at the third one, you can see that the orange bars are higher, which represent the burden on direct burden on people. Next, please. Okay, so the final slide. There is another slide, but I would like that people to look at this slide with a little bit of cautious, because this slide's based on one study that done in Bahrain to estimate the structure of the direct cost. And in this study, they estimated that 60% of the direct cost is related to admission, 15% related to procedures, 15% related to outpatients and laboratory tests, and 10% related to treatment. For sure, this will not be the same pattern in all the countries, but let us assume that this is the same pattern. If we assume that, we can estimate that almost more than 15 billion US dollar is spent in the region as a result of admission to hospital, and around 4 billion related to procedures, 4 billion related to outpatient and laboratory tests, and 2.6 related to medicine. But of course, this might change, and we need more research to try to understand the structure of the direct cost in each country. Next. So I would like to summarize with this last slide. In this region, we have 700 million population. 60 million of them are people living with diabetes. We lose 60,000 deaths every year, and the economic burden in the region is 60 billion US dollar. I would like to thank the team that worked with me, and thank you very much. Back to you, Hisham.
Thank you very much. This is really a great presentation, and with a lot of information. Thank you very much, Dr. Khalifa. So then we'll move to our third speaker, Dr. Theo Pipi. Dr. Pipi is the technical officer working here in EMRO office in NCD management unit. And she will introduce the regional framework for action on diabetes prevention and control. Pipi, the floor is yours.
Thank you very much, Dr. Hisham. Yes, good morning, good afternoon, and good evening to everyone. Here, I would like to introduce about our regional framework for action on diabetes prevention and control. Next slide, please. First of all, we would like to give a little bit information on the situation about diabetes in our region. As you can see from the graph, diabetes has reached the epidemic level in EMRO. So in 2019, more than 50 million people live with diabetes. And if we don't take action seriously now, it will be more than 100 million people will be living with diabetes by 2045. And again, EMRO is the highest prevalence of diabetes all over the world, compared to other WHO 5 regions. And we just learned from Dr. Khalifa's presentation that how big is the economic impact of diabetes in our region. And we also have high prevalence of obesity in EMRO, which is the most important risk factor for type 2 diabetes. Next slide, please. Yes, again, we have COVID-19, which is very negatively impacting people living with NCD and also diabetes. And according to our survey, like more than 40% of diabetes care and services are either completely or partially disrupted during COVID-19. So not only diabetes, but also other major NCDs such as hypertension, cancer, and palliative care services are also partially or completely disrupted during COVID-19. Next slide, please. Here, we would like to share a little bit of information on how EMR countries are responding to prevention, early detection and control and management of diabetes. This information is extracted from Country Capacity Survey, which was conducted in 2019. And we have three groups of countries, which is divided more or less based on their income level. And as we can see from the graph, if we look at the availability of evidence-based national guideline for the management of diabetes, we can see that the group 1 country seems to be working well. However, the group 2 and especially the group 3 countries, they have very limited achievement regarding in this indicator. And same for the availability of insulin at the primary healthcare facility of the public health sector. So this it gives a glance on how EMRO countries are responding to the prevention and management of diabetes. Next slide, please. Yes, again, in our countries, we face different types of humanitarian emergency, and managing the chronic diseases like diabetes could be really challenging in emergency. So we have NCD emergency kit to address the emergency situation for diabetes care. Our kit contains insulin and oral anti-diabetic and other oral NCD medicine, and also basic diagnostic equipment and renewable. We have so far distributed this in 7 of our member states and also beyond our region through our logistic hub in Dubai also. Next slide, please. So like our colleagues said, this year we have good news because we have the great global momentum for diabetes control as well as the regional momentum to do more. So just Professor Belkadia said, we are celebrating the centenary for the discovery of insulin this year. And all the member states all over the world just adopted the resolution on diabetes this year. And WHO also launched the WHO Global Diabetes Compact. And also in our region, during the 68 RC, which was held in October 2021 this year, all the member states adopted this regional resolution, technical paper, and this regional framework for diabetes prevention and control to accelerate our efforts against the diabetes. So in our framework, we have 4 strategic areas, which are the governance, prevention, management, surveillance, and research. So this was developed through the consultative process with the leadership from the member state. The member state comes and discuss and agree and adopted this framework, and which is to accelerate the commitments for the diabetes prevention and control in our region. You can download this framework in 3 languages from our website. Next slide, please. So we would like to translate these strategies into action. And one of the most important strategic intervention is the integration of NCD in the primary healthcare. So we apply WHO HEARTS for diabetes management, hypertension management, and CVD risk assessment, and adapt to the country and start implementing in the countries at the primary healthcare level in several of our countries. And several countries in EMR are like planning to implement this in the very immediate future. So as you can see from the map. Next slide, please. And we also would like to introduce some of the important regional initiatives on diabetes management, prevention, and control. So we are working together with IDF MENA to develop the capacity of the nurses to maximize their contribution in the diabetes care. We are also working with IDF MENA and Diabetes and Ramadan Alliance for documenting the practices and the supports needed to provide to PLWDs during Ramadan. We are also working on the online course development for diabetes detection and treatment, which is embedded under the HEARTS online course. This is intended not only for clinicians, but also the primary healthcare managers to be able to implement WHO HEARTS at the primary level. And we are also working together with our partners such as TASMA Institute for the Prevention and Management of Diabetic Food Complication Cost cause development and dissemination. And we are also working with the Endocrinology and Metabolic Research Institute, which is our collaborating center for diabetes prevention and control. So we would like to join our efforts and then, establish the network to maximize our efforts against diabetes control in our region. So we just presented how we just understand how big is the diabetes problem in EMRU, and then we have the solution. That's why if we don't act now, when? Thank you very much. Over to you, Dr. Hisham.
Thank you very much, PP, and thank you for your this presentation. So according to the agenda, I think we are still in time. So it's 12:15, I think. We'll move maybe to the other, the second session, which is we have like eminent participant from IDF and IDF MENA, and we'll start with maybe the first speaker. So we have with us Professor Hassanin. So Professor Hassanin, Muhammad Hassanin, is a consultant on endocrinology in Dubai Hospital, and he's also a member of IDF MENA. So Professor Hassanin couldn't join physically, but we have the record of his presentation, and maybe I will ask Maggie to play the record. So please, Maggie.
Bismillah ar-Rahman ar-Rahim. Thank you very much for the kind invitation and the kind words. It's a pleasure to be with all of you in this very important webinar. My topic is regarding accessibility of applications. Particularly, I will focus on cardiovascular and kidney problems. The data of the Swedish Diabetes Register confirm to us the higher rates of mortality in people with type 2 diabetes compared to those without type 2 diabetes. Most of this is related to cardiovascular death. So we know that type 2 diabetes is strongly linked with cardiovascular disease. We also know that diabetes is one of the main risk parameters for heart failure. When we go to chronic kidney disease and its relation to mortality, you can see in gray the rates of mortality for those who do not have kidney problems versus in blue in different levels of proteinuria or impaired renal function. So clearly the link for both is there. And because of this, various European and American guidelines, as well as regional guidelines, have all recommended, after the large number of cardiovascular outcome trials, looking into the impact of medication on the outcome, that SGL2 or GLP-1 receptor inhibitors, antagonists, must be included for those at high risk. In our Emirates Diabetes Society guidelines, we've accommodated this as well, and it's clear that people with type 2 diabetes with cardiovascular disease or target organ damage are at a higher risk. The ADA, along with the ASD in 2020, recommended that for anyone with an atherosclerotic cardiovascular disease, they ought to be treated with either a GLP-1 or an SGL2 inhibitor with proven cardiovascular disease benefit. For heart failure or CKD, they recommend an SGL2 as a preferred option or a GLP-1. It is then, if the HbA1c is raised, that we can consider the other therapy. And consequently, when we look into data from a survey that we conducted last year from many countries where the MENA region is very strongly represented, as you can see in this graph, nearly 6,000 patients. And from them, we can look into the profile of this group. First, look into here the total group. Their mean age is 55 years. Their mean duration of diabetes is 10 years. Prevalence of cardiovascular disease was 11.1%, and of chronic kidney disease was 10.4% according to the responses of the physicians. Use of insulin was 42%, and SGLT2 inhibitors were 14%, while GLP-1 receptor agonists were only 2.8%. Of course, when we look into those with cardiovascular disease or CKD, they are older in age, they have a longer duration of diabetes, and if they have CKD, they have higher rates of CVD and vice versa. And because of their duration of diabetes and their age, it is no wonder that the insulin use for them was 60 to 69%. Now, looking again into the profile, you will see the slight increase in prevalence in males for chronic kidney disease, but for cardiovascular disease, much higher prevalence in men. Unfortunately, in this important survey, the HbA1c for our patients, even for those who are high risk, was a mean of 8.6% or 8.7%, which is raised. Now, getting to the question of the presentation, the use of SGLT2 inhibitors or GLP-1 receptor agonist. Well, you can see here that it is ranging between 13 to 14% in those high-risk patients for SGLT2. For GLP-1, it's much lower, higher in CVD versus CKD, as you can see from the graph. Some are on both, but that's the tiny minority. And consequently, whoever have either an SGLT2 or a GLP-1 from patients with CVD or CKD and type 2 diabetes was ranging between 15 to 16%, which indeed is quite low. So going again to the same table, so we can see here that the SGLT2 inhibitors in whether CKD or CVD is no higher on the general population. And indeed, for GLP-1, it was slightly higher, but overall, the use is pretty low. If you look into the general utilization of the GLP-1, you will find that the massive proportion was from the two countries in the Gulf, Saudi Arabia and UAE, and perhaps that's related to cost. When you look into SGLT2 inhibitors, you will see that the largest actually utility of SGLT2 inhibitors was particularly from Pakistan, as well as India and Bangladesh, and then the other regions followed suit. So perhaps that's very much related to cost, because we know that there are some generic SGLT2 inhibitors. So we know that inertia could be an important factor. And we as physicians should not be hesitant to prescribe the right treatment for our patients, because that can lead to every single possible complications. The ADA is recommending to us that we must reassess inertia and the treatment therapy every 3 to 6 months. And if our patients fall within these two categories, then obviously, if they're available, we need to consider this. Now, we must not forget the issue is not just about SGLT2 inhibitors or GLP-1 receptor agonists, but certainly for these patients, very good control of blood pressure, very good control of lipid profile with statins, as well as aspirin use and getting glycemic control with whatever therapy we need. So, Mr. Chairman, the message here is that patients with type 2 diabetes and CVD or CKD, we need to choose the drugs with evidence of benefit to try to improve morbidity and mortality. We need to try this treatment and establish them as early as possible. And we need to look into improving availability of the essential treatment for the high-risk patients. Adopt these methods and encourage it. Treatment adherence need to improve, and physician inertia need to be minimized so that we can get our patients on the right therapy. And after all, we should have a systematic approach to all cardiovascular risk factors to minimize diabetes-related complications. And with this, I thank you with the photos of my beloved city, Alexandria. Thank you all.
Thank you very much, Professor Hassanin, for this great presentation, and also thank you for the take-home messages. Very, very clear messages, I think, to everyone. Professor Hassanin might join us for the for the discussion. So we hope so. So our next speaker would be Professor Abdul Basit. Professor Abdul Basit is the director of Bakay Institute of Diabetology and Endocrinology. And he's also in Pakistan, I would say. And he's also a member of IDF MENA region. And he will talk about the accessibility to insulin for type 1 diabetes patient in the context of the COVID-19 in Pakistan. Professor Abdul Basit, the floor is yours.
Hi, everybody. Can I be given the right to share the screen, or you will share it from me?
We can share it from you unless you prefer.
All right, I've done it. Have I? Can you see it? Can you see the screen?
Not yet, Professor Abdul Basit.
Just give me a tick then.
Okay.
And now?
Yes.
Right. So thank you for the invitation. My talk will be regarding accessibility to insulin for type 1 diabetes patients, especially in the context of COVID-19, especially from Pakistan's perspective. Now, we all know that MENA is an extensive region from Pakistan in the east to Morocco in the west. The people of diabetes, or burden, is enormous, 72 million people with diabetes. And the prevalence rate of countries like Pakistan, 30%, Egypt, 20%, and Kuwait, 24%. So it's high burden of diabetes. Luckily, it's more of type 2 diabetes and very minimal type 1. Unfortunately, the data for type 1 are not very clear yet. This also then leads to high economic cost, which has been highly elucidated by previous speakers. In Pakistan, unfortunately, 80% plus of the healthcare cost is out of pocket expense. So insulin is our issue for type 1 diabetes. For orals, the previous speaker have highlighted as much. So for insulin, what we started way back in 2008, project called Insulin My Life. World Diabetes Foundation helped us out to establish 34 centers across the province of Sindh. Province of Sindh is having a population of around 40 million, in which the non-affording type 1 were then given insulin through this project. 20,000 vials had been distributed, and 1,900 plus children were given insulin. They were not only given free insulin, but free consultation, mobile service, meters, strips, etc. through the project. It was 3 years of funding to establish the infrastructure, and from then onwards, which is 2012 onwards, for the last 9 years, we are generating insulin through various modalities. This is Life for a Child, which is an IDF-related project. Graham Moogly leads it, and then we got this affiliation with Graham Moogly and Life for a Child when they visited us. And so Life for a Child is one of our very strong co-partners. Only very recently, we have moved to another province, which is having much less economic development than province of Sindh. It is called Balochistan. Here, 400 type 1 diabetics, we are giving them free insulin. We had in another province, which is KPK, development of insulin bank, that is thanks to Professor H. Amir. The government there have got 23 district hospital banks in which they give free insulin, not only to type 1 then, but also to non-affording type 2. We have got people and pioneers like Professor Salma Tanveer in Multan. This is National Medical College, in which she gives free insulin. So free insulin is being now given in many places through many NGOs. I am the Secretary General of Diabetic Association of Pakistan, in which we give free insulin to around 300 children. At least this has been going on for the last 10 years or so. With this IML and the And this all activity, we were able to have World Diabetes Foundation project, then Life for a Child joining us. And recently we have developed a Health Promotion Foundation and Health Promotion Foundation integration with Life for a Child. Now we get insulin from Life for a Child, which is then distributed through Health Promotion Foundation, through Bach Christian Hospital, through Michi Zindagi, through NICH, through Children Institute. And so it's a matter of a chain development in which we are successfully delivering insulin to non-affording type 1 diabetics. Health Promotion Foundation, just introducing it, is a non-political, non-sectarian charitable foundation established with the aims of arranging medical facilities, healthcare, assisting in capacity building, welfare work for families, etc., especially creating awareness for type 1 diabetes, providing insulin to non-affording. Up till now, our project has distributed 300,000 plus vials, 1,200,000 plus pencils, awareness camps, sensitizing teachers, etc., etc. And also scientifically, the data is showing that when we give insulin to these non-affording children, their HbA1cs come down in 3 years' time to a very reasonable range, not the ideal most range, but very reasonable range compared to 9s and 11s before to 8s after the 3 years of insulin. We also get these articles published. We have got 15 articles published of this project, 8 are ongoing. Throwing some light on what happened during COVID. So this is 2019. Only in the later 2 months of 2019, we were struck by COVID, mainly in 2020. So these are the numbers in 2020, 2021. So if we see at the number of visits and the number of patients, there is not much during COVID. This is because for type 1, we were constantly in touch with them. We knew they will die without insulin. We have to ensure either their presence to us or our insulin delivery to them. So these visits could be tele-visits, WhatsApp calls, or personal visits, or visits to healthcare professionals, educators, etc. These are the glucometers issued over the 3 years. Again, a dip of, you can say, a few meters, but nothing like chaotic for the service delivery during COVID period. And these are the strips issued in these last 3 years. HbA1cs being done in the last 3 years. You can see a small dip of services in COVID, but I won't say that was because we were lacking the access to these children. It was because the traveling wasn't easy. It was because that our healthcare professionals realized that home delivery shall be taken on board. And this is the insulin issue over these 3 years. So Humulin R, Humulin N, we hardly give analogs or hardly afford giving analogs. And this is our premix insulin. I think I finish here because I know time limitation is there. I like to thank the national associations which collaborate with us, the international associations which are collaborating partners. This is my town, Karachi. I am very grateful to people like Isham, Jamal, Salim Salama, PP and Maggie. They are very cooperative. They keep us, on the move to work for our people with diabetes in Pakistan and to work for IDF, MENA, to work for WHO, EMRO, and we hope to be able to get continued support from colleagues like this. Unfortunately, we have 33 million people with diabetes in Pakistan, and 80% of the health and private sectors. Thank you for your attention.
Thank you. Thank you very much, Professor, for your excellent presentation and to you know, to share with us your experience and this experience in Pakistan. So now we'll move to the session 3, which is a panel discussion on a different perspective on access to diabetes medicine and care. And for that, we have with us 4 panelists. So we have with us Ms. Iram Ghafoor. Ms. Iram Ghafoor is a person living with diabetes. She's also a consultant diabetes educator, and she's a public health specialist and expert trainer for conversation map tools, and a core member of IDF MENA also. So this is our first panelist. The second panelist is Dr. Rifqi. Dr. Rifqi is the head of cardiovascular disease prevention department in the Ministry of Health of Jordan. So she is a specialist in community medicine, in the public health and epidemiology. And he is the key person on NCD, I would say, at the level of the Ministry of Health. He is responsible of the prevention and the management of non-communicable disease, especially cardiovascular disease and diabetes in Jordan. The third panelist is Professor Larijani. So Professor Larijani is a professor of endocrinology and internal medicine, and he is the director and the chief scientific officer of the Endocrinology and Metabolism Research Institute in Tehran University of Medical Science. And the last panelist, but not the least, which is Professor Hanan Gawish. Hanan Gawish is professor of diabetes and endocrinology unit in Mansoura University, and she is the chair of Egyptian Society of Diabetic Food, and she's also a member of IDF MENA. So I will start to ask the first panelist, which is Ms. Iram, about her experience. And I have 2 questions for you, Ms. Iram, on your experience in accessing diabetic medicine and care. And my first question would be, in your opinion, what are the major barriers in access to diabetes care and medicine? And I give you 4 minutes for this question.
Okay, thank you, Husham. And first of all, I would like to thank WHO and the organizer for inviting me to share my thoughts. So I myself have been a person with diabetes and living in a family which has many people with diabetes there. So to me, and I'm also working as Sham has mentioned, working as a healthcare professional. So to me, the first barrier which I am really concerned about is that there is no standardization of care, as the primary care is ill-defined and ill-trained. So the diabetes is not tackled at it should be. And people with diabetes have to resort in secondary care for the better care. And if they are there in primary care, so then they have to suffer from complications. And secondly, the 80% of healthcare is out of pocket or private, and just barely, or I would say minimal, 20% plus is in public sector. So this is how it creates a huge burden on people with diabetes. Access to medication is not uniform. There is a lot of difference, a huge difference between small and large cities, between rural and urban areas. And in regards of insulin, the cold chain has to be maintained, which is very difficult in that situation. Literacy rate is not helping us out. Population growth rate is not helping it out. And I would not say that government is not aware or not doing anything, but I must say that government does try to support diabetes and NCDs. But unfortunately, when the time of implementation and execution comes, then something more come along, and that the thing get diluted. So in past, we had some national action plans, but unfortunately, they were not very much materialized. And the other barrier, which I think there is the inflation getting high, the Pakistani currency is getting devalued. So the medicines and the access to care is getting much more difficult for the people with diabetes. And insulin monopolies by few multinationals, rather than we can have some local providers who can make cheap insulin, and glucose meters are not cheap. They are not readily available here. So again, because the technology is again monopolized, over and above, we are facing the scarcity of capacity building and human resources. We don't have well-trained nurses and nurse practitioners. The diabetes educators are countable on fingers. We don't have podiatrists, so we have to trained foot care assistants. Right now, we have 33 million people with diabetes in Pakistan, and 11 million are on verge of developing diabetes. And this is also very alarming that 10 million children are presenting with obesity. So you can imagine that how huge burden we are facing right now and how much resources we needed. And unfortunately, we don't have that.
Thank you very much, Ram. And maybe quickly, my second question, it's so what do you think, what makes like compliance difficult in countries like or low and middle income countries?
Well, compliance is multifactorial, and there are many factors which influence compliance. If I'm going with the Pakistani perspective and the countries around Pakistan, then I would say the first thing is mindset and priorities. If usually the breadwinner or the mother of 4 or 5 children come up and present with diabetes, initially they don't have any pain because diabetes is painless on initial basis, a silent killer. So they don't give any value to it because mother's priority is children and fathers prefer to earn rather than take care of himself. So this is the issue. The main reason for non-compliance is their not giving value to their health and poor priority settings. And the next, I think, reason of compliance is a stigma. For example, if I will be there and I will tell you that I am a person with diabetes in my setting, in my country, then suddenly they will come up with something. Oh, you have diabetes. Okay, can you do this? I think you can't do this. What will happen with your family? What will happen with your children? Can you eat this? And they start talking about it openly, and people try to judge you. They discriminate you. So this is how that create problems for people, and they get reluctant, and then they hide it, and then they start moving with other people in a society, like they go to parties and offices and meetings and eating everything and doing everything just to hide it, and ultimately they die with them. So this is the main thing that I should pointed out that stigma is attached with diabetes. That's why people are non-compliant too. This is one of major reason. And then cost comes, because if you go for the best medicine, they are very expensive. You can't access them. And if you go for the cheap medicine, they don't work. So people with diabetes shop around. They change doctor by doctor, and then every doctor give insulin or any medicine which they prefer, and that's how the person get more confused. So we have no set standardized guidelines. There is no pattern for the doctors which should be followed to treat diabetes. And I must say that again, it is the weakness of primary care infrastructure, because if the primary care is good and strong and have set of guidelines and training, then nothing will happen like this. And the other thing is that the healthy food items are very expensive, and the junk food is cheap. For example, in my country, in my culture, if you want to buy fruits at night, maybe at 11 p.m. or at 12 midnight, that it will not possible. But you can order Food Panda, and you can access you can order the samosas, and you can order the pizzas and burgers at that time, all around the night. So, there should be some taxation. There should be some rules for that. And I think this is not only about me, the person like me, that who are not compliant, or maybe who they want to be compliant and they want to be have more good things implemented in their life, but there are many factors which push them, and there are many issues which should be addressed to improve compliance among people with diabetes.
Thank you very much, Ms. Iram. And I saw that there are, I think you will have a lot of questions, but thank you for sharing with us your experience and your thought. A very great insight. So I'll move to the second speaker, our panelist, Dr. Rifqi. So Dr. Rifqi, I would like to ask you also maybe two questions. And the first question will be on the challenges on access for care and drugs for diabetes. We know that you are managing the national program in Jordan, and we would like to have maybe your thought on that. Please, Dr. Rifqi.
Yes, thank you very much, Dr. Hisham. Thank you for everybody. And I'm really very happy to be with all of you this morning. About the access to diabetes, which is the theme for this 2021 World Diabetic Days, I was looking for any numbers about access to diabetes all around the world. And I think we really have a very limited data about this issue. So I think it's very important, this theme for this year about we have to take care, we have to study more about the access to diabetes around the world, and especially in each country. Well, here in Jordan, we found out in our last STEP survey that 18% of our population who have diabetes do not take their medications. So we don't know why they are not taking their medication. Is it because of the access to the health centers, access to the medication, access to doctors, or because they are not interested in taking their medications? They believe that they have no symptoms, they have no signs, so it's nothing happening to them. So why they are taking medication? We don't know why. So this, I think, it has to be studied. We have to see how many patients in each country they are not taking their medication, even though they know that they have diabetics. They know doctors told them that they have to take their medications, but actually they are not. And we found out also about 11% of our diabetic patients was living in Jordan. They are taking herbal medications and not following doctors' recommendations for treatments. But why they are taking herbal also, we don't know why. Is there because they have no access to medication or no access to health centers, or because of their beliefs that herbal treatments is better than chemical treatments? We have to discuss that. We have to study that more in depth. But actually here in Jordan, and I looked at the website about the percent of people who have diabetes, and they know they have diabetes, but they don't have an access to medication. Actually in Jordan, as I said before, 18% they're not taking the medication, but we don't know the exact number for those who don't have access because they don't have money, or the cost of medication is very high, or we don't know why the reason. So about here in Jordan, we found out in our STEP survey that about 60,000 patients of diabetic patients in Jordan, they are not taking their medications. So this number is very high for us, and we have to know why they are not taking the medication. Even though in Jordan, all Jordanians more than 60 years old are insured, and all children less than 5 years or 6 years old are insured. They don't have to pay anything for treatments or for health diseases. And we found out also that if those who are not insured, which represent in Jordan 18%, also 10% of the population are not insured. So these persons, I think they have to pay a lot of money for the medications, because in our studies we found out that treatment of diabetes cost about average about 80 GDs monthly for each patient, which this represent about 20% of their income, the family income in Jordan. So it's very expensive for them, too much money for them if they are not insured. But as I said, it's about 82% are insured, and beside all over 60 and all less than 6 years are insured. But here in Jordan, we have more than about 700 health centers, public health centers, and this health center is everybody can access there. We have no problem for access to health centers. We have also no problem to access to the medications if the patient wants to, but those who are not insured, this, yes, it's a problem for them and costs too much money if they are taking insulin and not tablets. I don't know if that's answering part of the question, or if there's any other question, please.
Yeah, thank you very much, Dr. Rifki. I have a second question, but it's well noted that you know about limited data, and you said that many people are not taking their medication or taking a herbal medication, and yeah, the right question is why they are doing this, and I totally agree. But my second question is, what could be, in your opinion, the enablers and facilitators in your context, in the context of Jordan?
Well, about the health centers here in Jordan, all our health centers are treating NCD patients, all the health centers. And we have a special form, a special file for NCD patients in each health centers. And we have a reporting system for diabetes, especially for diabetic. There's a tool, special tool for diabetes mellitus in Jordan, and for hypertension. It is reported by an IRIS, an interactive electronic reporting system for tablets. And we have 1,200 tablets distributed to the 700 centers to register everybody with diabetes and hypertension. But actually, in the field, it's not, the completeness is very low. I think not more than 30% of patients are registered in the system. That's one thing. Other thing, as I said, accessibility to health centers is we don't have any problem for availability.
I don't know if it's only me, but maybe Dr. Rifki, we lost you.
Yes, the voice is cutting and we lost it.
Okay, we can maybe move to our third panelist, which is Professor Larijani. And Professor Larijani is as I mentioned. Yeah, I don't know, Professor Larijani. So the question is for you. So Professor Larijani is working with EMRU through the collaborating center, and they're doing a lot of great job and supporting also EMRU in the field of diabetes and other topics. My question for you, Professor Larijani, is regarding maybe the challenges of diabetes control during the COVID-19 in Iran, and what are the challenges and the lessons learned for diabetes control during the COVID-19 in Iran? And you have the floor for 8 minutes.
Thank you. I would like thanks Dr. Hashim for this meeting and the WHO team. If you agree, we started with some slides about this topic, your question.
Yes, you can share your screen. I don't know if Maggie, if you can give the floor to Professor Larijani too.
Thank you.
To share his screen. Now we can see your screen, Professor.
Good. Your topic is about the challenge of diabetes control during the COVID time, and we will try to mention some words about the diabetes prevalence and the COVID situation and the COVID and management of diabetes. All of you know about the situation of the world increasing rate of the diabetes, and in MENA region. Unfortunately, the situation of the MENA region, based on the information, the number of the people with diabetes in MENA region will be increasing by 96% from the 2019 to 2045. And this is the trend of increasing of the rate of diabetes in all of the world and in the region. But unfortunately, in the region, the MENA region has the highest age-adjusted comparative prevalence of the diabetes. And this is the important voice about this situation. This is the situation of Iran. And we have two evaluation of the prevalence of the diabetes. And you can see an increasing time trend of the diabetes prevalence is observed from about 10% in 2005 to about 14% in 2021. And another important things, the difference between the highest and lowest age standards diabetes prevalence is in 2016 is 7.5, and into 2021 is 10%. It means the difference between the different state is increasing. This is the trend of the rate of the mortality and prevalence of the fasting and relation to the fasting plasma glucose between the different years. And this is the difference between the highest and lowest age standard diabetes prevalence among Iranian district is 18%. And also the diabetes awareness and diabetes converge and the effective care for diabetes were estimated across the 400 29 districts of Iran is different to each other, and this is important for the programming and management and changing and designing some intervention. The other important thing is based on the estimated diabetes prevalence and its complication and the population of the different region, the number needed visited of this patient was calculated from the different classes of the diabetes people using guideline, and we designing three kind of the clinics, type 1, type 2, type 3 in different state of Iran. And we designing from the second edition of the NCD and relation to diabetes, ischemic heart disease, in the COVID era. And this is very important. Many of the guideline is changing the relation to the situation. This is the guideline for some of the complication, for example, for diabetic foot, and you can see the adopted guideline of the world is adopted to the situation of the country. And this is the developing guideline of the prevention, monitoring, and treatment of diabetes and complication of the diabetes. But in the COVID era, in the Iran, you can see the situation of the COVID. We have many spike of the situation, and this time the situation is not bad. And I think there's some of the management of the expansion of the vaccination is effective. And the social responsiveness of the MRI to the situation of the COVID, done many things with the collaboration with the different group in the relation to the COVID time. But from the initiative to COVID time for the management of diabetes, the selection, careful selection of the medication is very important. Fortunately, over than 94% of the population have access to the insulin and the drug, because many of the insulin and the drug is prepared by the manufacturer within the country. And this is the result of the assisting National Registry of Hospitalized Patients with severe acute respiratory problem with diabetes and non-diabetics. You can see over than 35,000 people with diabetes and over than 200,000 people with diabetes. And you can see the complication, and you can see the underlying comorbidity relation to diabetes have a risk for this group. And we have another study about the NCD. 1/3 of the people with the COVID-19 and severe COVID-19 have some underline of the NCD, and 8% of this group have diabetes group, and the provide by the Ministry of Health for evaluation of this. The registry is very, very important for management of this group, and the real situational data is relation to the NCD and to the diabetes. This is the other study we done in the COVID era. During the COVID situation, reduction in diabetes visit across the country is, you can see, reduction in diabetes visit in clinic, reduction in diabetes visit in physician office. And because of solving of this problem, we designing some, and the parameter of the metabolic parameter of between the COVID time, cholesterol level, LDL, HbA1c, and other, you can see in this slide. And this is the insufficient access to the healthcare team is 1/3 of the population. And the other things more careful about the taking of medication is come down, and you can see 40%, about 40% of the population. Because of this, we're moving to the virtual situation. Only an estimated 25% or fewer people receive formal diabetes education. And because of this, we created Diabetic-gram, and it is many information for the COVID-19 and diabetes guideline for the diabetes care in COVID time. All of this enhancing access to the diabetes care and its complication by providing of this modulation for the people and for the population with diabetes. And the diabetes registration system is increasing and over than 100,000 registered, visited more than 4,000 of this group is diabetes. And this group is managed by the virtual management and virtual evaluation of the situation. In conclusion, global time trend to estimate the projection of the diabetes prevalence and the increasing is very, very important issue. Diabetes should be considered a risk factor of rapid progression and prognosis of the COVID-19. COVID-19 necessitates to the transformation in diabetes care through the integration of the technology. And we did multi-modification in diabetes care in COVID time, enhance access to the diabetes care, and had tried to increase the education, visit-based guideline, and unfortunately, the prevalence of the diabetes with all of the activity increasing by the time. Thank you for your attention.
Thank you. Thank you very much for this comprehensive presentation, and thank you for sharing your experience as also a WHO collaborating center. A lot of I would say a lot of lessons learned can be learned from your experience and also can be shared. I think so. Thank you very much, Professor Larijani. Then we'll move to our fourth panelist, Professor Hanan Gawish. And Professor Hanan, my question to you is the access regarding the access to medicine and care for complication of diabetes in Egypt. And yeah, we know that you have this leadership in diabetic food also within the IDF MENA region. So what are the barriers against implementation of prevention food care in diabetic patients in Egypt?
Thank you so much, Dr. Hisham, for inviting me for this nice meeting. And thank you all the team working on that meeting. And I hope that this meeting will not be ended by the end of the meeting, but it's going to be translated into active steps on the ground in the MENA region and in all our countries. Are you hearing me?
Yes, we are hearing you clear and loud.
Thank you. I'm going to put it into point. And number one of the barriers, in my opinion, is the absence of podiatry education, both in Egypt and in the MENA region. Although there are some few podiatrists who are Western qualified in the Western countries, and they are working now in the Gulf, but they are not enough for sure. And the absence of podiatry has made the food care, in my opinion, as no man's area of interest. The second barrier is that physicians are usually glucocentric. They are mainly caring about prescribing drugs to control glycemic state, not by the ideal drug, as we have heard from Professor Hassanein, but they are prescribing what is available for them. So they do not have mostly enough time to care, whether in hospital or in the private sector, to care about complication, not only the food. They don't have time to screen for complication, for early detection and better management, or to follow the implementation to guard against the all complication for patients living with diabetes. Number three, physician has a lot of work to be done, and nurses are not recognized by our authority nor by our patients to take part of the job to facilitate for physician, giving him more time to do a better control and care about complication. Number four, there is no governmental funding for preventive food care. For example, the therapeutic footwear, which is almost by most of the guidelines and most of the implementation is crucial for the patient at risk for ulceration, is not funded. Yet in our countries, for example, prostheses for the amputees are sponsored by the government. which is a bad thing and a huge difference from the developed countries. Number 5 is that there is no structure of healthcare referral system as the one present in the developed countries, where patients know their way. They can go to primary care or specialist if they need, or center of excellence. Although the food clinic had clear in the developed countries, which is not a hard task to be applied, clear definition of minimal model food clinic where the patient has to go first, that belongs to primary care physician, and then move to the moderate care food clinic, and then to the center of excellence if they need. And this is my 5 points in view of the time, but there is long list, but this is the most important five barriers in my view.
Yeah, thank you. Thank you very much. And to the point, very clear. Thank you, Professor Hanan. And we can just talk about education, not enough time to screen for the complication, the role of the nurse, and to recognize not only doctors, but also the nurse and their role, and funding, and of course, the pathway of care or referral system. And there are really clear barriers. I would like to thank you very much for this. Is, I think, a strong message. But in your opinion, Professor Hanan, how to overcome these barriers? Any insight, any thought about the solutions?
Yes, the solution is very easy, but the lack of organization between the working group and the stakeholders and professors of diabetes and the Ministry of Health and the Ministry of Higher Education, in my opinion, is the worst part of the scenario, because the solutions are very easy. As regards the absence of podiatry education, we have a lot of general practitioners and nurses that could be trained, and we have done that to overcome the absence of podiatrists. And this is a problem, that this is usually supported by NGOs. Like our first project was done by the World Diabetes Foundation, and the other training of podiatrists, of practitioners and nurses to be working as podiatrists is usually done by the Egyptian Society of Diabetic Food and the Gulf Society for Food Care, and the IDF, MENA Region Diabetic Food, has shared us one. So it is usually done by NGOs, or is sometimes done as initiatives by the industries, which is not without an aim. It's usually without a secondary goal that make it not the ideal, but it works sometimes in Egypt, as we have now 2 initiatives done by the industries. But there is a big but here. That should be done by the authority, as those trainees that you make, they're valuable one when they are well-trained for more times, and for example, basic course and advanced course, they can work as podiatrists in their areas, but they need to be certified by the authority to avoid medical legal and to give them more power in their centers to work and not to be attacked by other specialties working on diabetic food. And they also need to be compensated, because they're doing that job as everyone working with diabetic food now, in addition to their routine work. So this is my solution for the absence of podiatry. For number 2, which is the glucocentric attitude of most of the physicians, this is very easy solution, as everywhere in the MENA region now, a lot of continuous medical education is done, not only for diabetic food, but also for how to care about the retina and the rate of the guidelines for transferring your patient to an ophthalmologist, and also how to screen for the kidney. So we are treating that defect by always continuing medical education to our practitioner, but caring about the complication as regard to screening, early detection, and implementation needs to be authorized system to do it, not according to the willing or the mood of the physician. As regard the nurses, it's very easy to put criteria for anyone to be licensed from the nurses as an educator, for example, and there was a lot of effort done by the IDF in our country, and I don't know definitely for sure in other countries in the MENA region. But these educators are usually lost again in the Ministry of Health, so you can hear that they are no more working as educators. These nurses, which you spend time with them to educate for food or for education or for whatever you want them to work, they should be not only licensed by the authority, but keeping their places to work in and not wasting the effort done in educating them. As for the barrier number 4, which is the non-governmental funding, there should be some policy maker, and I think the WHO can work on that, and the IDF MENA region can work on that in different countries with the Ministry of Health and Ministry of Education, that experts on the field can provide data about cost saving. It's not accepted for complication that a Ministry of Health, like in Egypt, provide prostheses for amputees or reimburse dialysis for end-stage kidney disease for people living with diabetes or even without diabetes. They reimburse the dialysis everywhere across the country. Or the very expensive intraocular injection, which our ministry support the centers to inject, or laser, but they do not spend £1 in prevention, as for example, with the very cheap therapeutic footwear that should be available for our patient as medication, as insulin therapy, as glucometer. They are not having that in mind. My last point, which is that there is no structure for healthcare. I know that our government is doing a lot now in the new insurance system in the government, where they have started to work with family doctor, primary care physician, and not to see the specialist unless the primary care physician refer the patient. So the system is put now. But as for complication, there should be a clinic caring about complication in that integrated system for the foot, for the diabetes, where the patient with diabetes is moving from the primary care to specialist to be screened for all complications, not only the foot, but the retina and the kidney. And I hope to see that one day in our country. But for the foot, it's very easily solved in our country, because my center was able to develop a satellite foot clinic around us across the country with a very generous grant from the World Diabetes Foundation. Then another generous grant from the IDF MENA region to develop others in our country and in the MENA region. We have attendees from the MENA region. And these trainees are usually linked to the clinic. So they are doing the job of the minimal model food clinic, intermediate food clinic, and whenever they need a strategic plan or a consultation or so, they refer to our Mansoura Diabetic Food Clinic, which is working for them like a center of excellence or referral. But I hope this is for the food, but only for our trainees, and they are minimally in view of the other physicians and nurses seeing diabetic foot across the country. So I hope to develop a system where every patient with diabetic foot or early retinopathy or early nephropathy for people living with diabetes know where to go. This is going to be very crucial if we are actually willing to decrease the complication. And thank you so much for inviting me again. And I hope that this meeting is going to be reflected or translated to active steps as by two very great organizations as the WHO and the IDF MENA region. Thank you so much.
Thank you. Thank you very much, Professor Hanan. And I hope also, so we are working with all the partners, you know, and we are expecting to have like guidance and from this kind of meetings and webinars. As you mentioned, the solutions are, as you mentioned, easy. You mainly highlight the role of the government. I would say that needs a commitment, and maybe the health authority should invest, as you rightly mentioned, on human resources. This is one, on funds, of course, and not having some areas neglected, but also to review I would say, the health system to be able to respond to diabetes complication. And the message was clear. I would like to thank you very much. I think I don't know if we can get back to Dr. Rifki, because we missed the second question. I don't know if Dr. Rifki, you are with us and you are able to. You mentioned that there are limited data in Jordan, and many people are not taking their medication or are taking alternative or herbal medications. And of course, you talked about the insurance and the people who are uninsured. You talked about maybe the public health centers in Jordan, but you wanted to tell us about what could be the enablers and the facilitators in your context, and we would like to learn from you. So are you able maybe to give us your feedback on that?
Yes, thank you very much again. I'm sorry I had a call from telephone, so I just lost communication for a while. Well, it's about, as I was saying, about the access to health centers in Jordan. The main problem is our health insurance is not covering all people, covering only about 82% of the population. The others, we have yes problem about getting their medication, or because of the cost of the medication. And also, I totally agree with what Dr. Hanan was talking about, the health education and the awareness about especially about the diabetes. As everybody know, diabetes is a silent disease. There's no symptoms, no signs, or could be without symptoms and signs. So patients, they feel that no need for medications. So health awareness and health campaigns and health education is, I think, critical point here for increasing the access of patients to health centers and taking their medications, and be sure that they are controlled, so they will not go to the complications. This is a very important point. Here in Jordan, I think, yes, we have to increase our awareness and health educations for these patients. In our health centers, till now, we don't have an educator in the health centers. We have doctors, nurses, labs, X-ray, but health educator, it's in very few health centers, and maybe in very big comprehensive health centers, maybe you find an health educators, so doctor can refer patients who are uncontrolled for diabetes, or patients who are not taking their medication regularly. He can refer them to the educator. But I think we need a health educator for NCD patients in every health centers, either primary or comprehensive health centers. And also, I think we have to increase our national campaigns for diabetes in Jordan and all countries. Like we have very good campaigns, for example, for breast cancer. We have yearly big campaigns for some diseases, but for diabetes, unfortunately, we don't have big campaigns and screening programs to be free of charge, and to be like booths in the street and in the gardens. It's not supposed to be in only health centers. It should be in the community. And also health awareness about diabetes. Like now we can see health awareness and education in the TVs and everywhere about COVID. Very huge campaigns for taking the vaccine, and to be wearing the mask. These campaigns are very huge for COVID. I think we need the same thing, campaigns and health educators in all our health centers, either in governmental or even in private sectors. I think this is the most important measures that can be done to prevent complications and to control those who are diabetes and prevent for an impaired diabetic patients to go to the diabetic disease. Thank you very much.
Thank you very much, Dr. Rifqi, and thank you for your thought and sharing with us your experience. And I totally agree with you. I think when saying that there are a lot of lessons we can learn from COVID, and there are a lot of we are dealing with the pandemic. I think we need to think the same with the diabetes, as it's also a kind of pandemic, I would say. So thank you very much, our panelists. We have we are little bit beyond the time, but you know, in our agenda we have a few minutes for discussion. I don't know if I couldn't see any question in the QA box right now, but I don't know if anyone want to take the floor, have any kind of questions. Maybe quick, we can take one or two before the poll questions. Okay.
Hisham.
Yes.
Now you want to discuss what can we do better to improve access to diabetes medicine?
Well, just if someone has any questions, we'll have the guidance from the audience. Yeah. We have 3 questions for all the audience, so to maybe to give, they can share with us their guidance. But I would like to know if there is anyone who has a quick question, burning question for all the panelists, so we can maybe answer. Otherwise, we can move to the other session. And I can see here, okay. Community. Okay, so this is just maybe there is no, I think, questions. Yes, please.
Hisham, there's a question regarding how can nurses work in the community? Yes. That is from Sadia Kamal. I suppose the answer is that yes, in our parts of the world, especially, the nurses have to come forward to play the role. In Pakistan, we are badly handicapped in a sense that nurses are not specifically trained for diabetes as we have trainings done in the developed world. So we've started this initiative of involving the Pakistan Nursing Council, submitting to the hierarchy that there shall be a specific diabetes related module at undergraduate nurses training level. Then whilst they are doing internship, they shall have few weeks of diabetes specific training. Then we are suggesting nurse practitioners and advanced nurse practitioners training into diabetes. This we have moved to Pakistan Nursing Council level. We are now planning to move it to ministry. Our estimate is that there are around 0.1 million nurses in Pakistan. If we can train them at baseline level, so from primary care or from outreach areas till the primary, secondary, and tertiary care centers, we shall have nurses playing their role into diabetes.
Thank you very much, Professor Abdul Basit. I can see Rida El Badawi, who raised his hand. So Rida. Just unmute yourself and ask your question.
I'm Dr. Rida El Badawi. Thank you for giving me the chance to talk about what I want to tell. I'm Dr. Rida Al-Badawi from Pana University. I have a talk or a subject related to the process that before diabetes mellitus development and what's called fatty pancreatic disease. Fatty pancreatic disease can lead to both endocrine and exocrine dysfunction of the pancreas, and so lead to diabetes mellitus. This is what I wanted to tell, and the red flag for this issue, because it will lead to diabetes mellitus and its complications. So are in need to more exploration of this issue, because I have 3 studies at Pana University, and the issue started to be raised at Egypt here. I have a project also funded from academic scientific research at Egypt. Thanks a lot. That's I want to tell. Okay.
Thank you very much. Thank you.
Thanks. Thank you.
Okay, so then maybe we'll, because it's almost 1:30, we still have like a few minutes, and we'll invite Maggie, to run the poll questions. So we'll have 3 questions for the audience. So the first question will be regarding the role or the engagement or the meaningful engagement of people living with diabetes. The second one would be on the access to medicine. And the third question I would say would be in the agenda that should be maybe prioritized to achieve access to quality care in our region, for of course for people living with diabetes. So we would like to have your feedback, and maybe, I don't know, Maggie.
Yes, doctor.
You can launch the questions, please.
Yes, maybe
the first one.
And just let them know that each question will have 3 minutes.
Okay.
To be replied, and then the poll will be closed. So they will be launched one by one.
Thank you, Maggie. Well, the first question is, so what would be the 3 priority interventions? So we are inviting you to choose maybe among these 3 priorities interventions. So you will recommend being implemented to create enabling environment to empower the people living with diabetes to improve access to care and medicine.
I just want to make sure everyone has the ability to choose, because I'm seeing no votes yet at all. So do you have the option to choose from the options?
Yeah, if you can click on the items and choose 3 among the list. Someone raised his hand. I don't know if it's related to the poll. It's Michelle.
Yes, we just chose 3 and submitted the answer. It's saying that there is an error. So I think there is an issue with the submission of the answers.
Oh, okay. I don't know if then we can move to the other question. I don't know if it's the same problem.
We can try.
Yeah, let's try to let's move to the second question, Maggie. I can see that, yeah. Then Maggie, we can move, I think, yeah.
Do I close the poll now?
Yes, please. So we can move to the third question. And I don't know if we can get back to
We
the
can.
first one.
I can try to launch the first one again.
Thank you.
The first one didn't launch, so I'll launch the third one and try to
Yes, please.
re-edit the first one. The poll will allow you to choose more than one option, but please limit that to 3 options so that we can know the most important ones.
I think it's fine for the third question. Okay, Maggie, and I think we have the response. Yeah. I don't know if we can launch the first question. Otherwise, at least we can give the answer for the 2 questions. So here, for example, for the question 3, so that maybe the audience prioritize the capacity development for primary healthcare workers. So to be able to make timely treatment decision and evidence-based simplified guidelines that are tailored to individual patients. And we have also the second priority, we have that, I think the same thing So the audience maybe prioritize the integration of diabetes care and management in PHC, and also to ensure care system support, team-based care, community involvement, patient registries, and decision support tools to meet patient needs. And also to facilitate the engagement with the private sector and invite the private sector in capacity development activities to ensure the delivery of quality diabetes care. So
we can
this is
still launch the first question, Doctor.
Yes, please. Yeah, okay. I think it's important for us. So yes, please, we invite you to also to prioritize these items, and we'll take maybe 2 more minutes before ending the webinar. Thank you.
It's not working again.
Okay, so if it's not working, means that I think there is a problem with the question, not with the Zoom. I don't know what is happening. So, but it's maybe just fine. I think we are 15 minutes beyond the time. Can you share just maybe the response, or I took a photo. I don't know if it's possible for at least the question 2. But for the drugs and the medicine, yes, thank you very much. So the response was, you know, the audience prioritize reducing the price in terms of pooled procurement mechanism, aggregated demand of diabetes product, etc. So maybe the second would be education and improving education for policymakers. I think it was 50% of the audience choose this priority, as well as the health insurance. So to guarantee the availability of health services free of cost or based on a low co-payment. So these are maybe the 3 main priorities, I would say, by the audience. And why we are asking these questions? Because we want to know what would be the priorities in our work for the next couple years. So this is the main objective of this webinar. There were a lot of recommendations, a lot of, I would say, a clear or direct recommendation for us and the domains where we can work. I would like to thank you all for your participation today, and I think we don't have enough time to go through all what happened today, but I think we'll have the opportunity also to meet together and to discuss more about the diabetes. We know that diabetes is a bigger challenge in our region, and it's a bigger challenge everywhere, I would say, even for developed and low and middle income countries, which mean that, yes, we have or we think we have the solutions, but I think the guidance, the guidelines, what exists already should be maybe adapted to each context of each country. And this is also something well highlighted in many presentations. So thank you very much for your participation, and we'll of course share with you the presentations we have. We'll ask the presenters to if they allow us to share with you also their presentations, inshallah, and we'll keep in touch. Thank you again. I don't know if Professor Belkhadir, do you want to say a few words? You are muted.
At the end of this wonderful meeting, I would like to express my deep thanks to the organizers from WHO, MRO, also to the speakers and for all participants. The celebration of World Diabetes Day 2021 is a wonderful occasion to remind the importance of the prevention of diabetes. It's clear that the theme of this year, access to diabetes care, if not now one, with different presentation and fruitful discussion, shows the importance of taking coordinated and concerted actions to confront diabetes as critical global health issue. Thank you again, and hope to meet you soon face to face.
Thank you very much. Thank you all, and bye-bye.
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 Thank you. Bye-bye. Thank you.
Bye. Thank you.